Good afternoon, everyone. I'm Dr. Aravinda Lochani, consultant neonatologist and pediatrician at Cuddles, Kondapur. In this video, we will discuss about the clinical approach to critical congenital heart disease. This is one of the most common and important differential diagnosis in neonates as well as infants within the first 1 year of life. So, what is defined as critical congenital heart disease? It is the any heart disease in a baby requiring either a catheter-based or a surgical intervention within the first year of life. So this was defined by the American Heart Association. In babies who require any surgery or catheter-based intervention in the first year of life, this can be considered as the critical congenital heart disease. Coming to the incidence, it can be around 9 to 10% in babies per 1,000 live births. So this roughly accounts to about 2,43,000 babies who require any intervention related to the heart in the first year of life. It also contributes significantly to the neonatal mortality in that it is around 28% and for infant mortality around 40%. So when do we suspect any baby about the critical congenital heart disease? So the common presentations of CCHT are either it can be a cyanosis in which the baby presents with peripheral and central cyanosis with decreased oxygen saturation, or signs of poor systemic perfusion. The baby may present on day 3 or day 4 of life with signs of shock, poor pulses, and bradycardia, or it can be either an increased respiratory rate. Silent tachypnea is common in babies having the cardiac problems versus respiratory diseases, and also as a failure to thrive, decreased feeding, poor activity, lethargy. So these are the common things, signs of presentation in babies with the critical congenital heart disease. So the heart diseases generally they are diagnosed during the antenatal scans. If the baby is subjected to fetal echo, then also most of the heart diseases can be diagnosed. Or the next important step in diagnosis is the postnatal pulse oximetry screening or postnatal echo and clinical examination. So the most common acyanotic congenital heart disease is coarctation of aorta, and the most common cyanotic congenital of heart disease is transposition of great arteries or tetralogy of Fallot. So both of them present almost equally. So we will discuss this presentation in the based on first clinical scenarios and then the approach to CCHT. So whenever a baby comes with any signs of respiratory distress, so how should we approach? We should generally approach it from the antenatal history itself. So this some heart diseases are common in families, particularly the acyanotic heart diseases and DTGs. DTGs generally carry a low risk of recurrence. So some genetic syndromes are also associated with the critical congenital heart diseases. And whenever we are inquiring a parent about the family history, we will ask the maternal factors like maternal diabetes, hypertension, maternal obesity, and maternal intake of any drugs like phenytoin, retinoic acid, and any in utero infections like flu and influenza, and any torch group of infections also carry a significant risk for congenital heart disease in the babies. So this is about the maternal history risk for the families, and also the antenatal part, and then postnatally we will discuss under the clinical case scenarios. So here we are seeing a term baby who was born by LSES in view of non-progression of labor with a birth weight of 3,250 grams. The baby cried immediately after birth. Then the baby was noticed to have respiratory distress with the cyanosis, saturation being 80%. So the baby was brought to NECU and started on bubble CPAP support. Heart rate initially was normal, 145 per minute, and there was no murmur. Tachypnea was noted, which is 68 per minute. Retractions are minimal. And still after starting CPAP and giving some oxygen support also, the saturations continued to be at 85 to 89%. So corrected the respiratory part like supported with CPAP and still the saturations are not improving, then we should suspect about the cyanotic heart diseases. So then the baby subsequently needed intubation with the pressure settings of 18/5 and FiO2 being 50%. So if this had been a late preterm and all, so after this is the X-ray of the baby, which is like HMD picture. If this had been a late preterm baby or a term baby with the um, history of maternal diabetes, then we might go for a first dose of surfactant. Here, even after giving surfactant, if there is no improvement, what we will suspect? So next, the possibility will be the heart disease. In this case, it turned out to be a case of TAPVC. So that is about the first baby. So whenever it is not responding to the cyanosis is not responding to the initial respiratory support and it doesn't look like respiratory cause, then we have to think of the next possibility as the cardiac. So coming to the second case, here we have a 25 days old baby who presents with the cough, cold, and decreased activity and decreased feed intake in the last 4 days. This is like worsening of the respiratory distress and failure. In this way, the baby had presented. The baby was taken to the hospital where the baby was brought in a gasping state with bradycardia and seizure-like activity. And the baby had desaturations up to 70%. The baby was intubated immediately. And in view of this central cyanosis and severe desaturations, the baby was suspected to be having a cyanotic spells. And the baby was started on oxygen and propranolol was given. The baby also had a hypotension, hence the baby was started on inotrope. So this is the picture of the baby who had a cyanotic spell-like picture in which there was a desaturation and leading to poor respiratory efforts. So then they have done some investigations. The X-ray was showing this kind of picture. In this, what we can see that the apex of the heart is on the right side with showing dextrocardia and well-inflated lungs with increased bronchovascular markings. So the lungs are well expanded. So this is suspected to be a cardiac cause, and then subsequently the 2D echo was done, in which it showed that the baby is having a dextrocardia with right-sided apex and AV-VA discordance. In that, it means that the ventricles are switched to the opposite sides. In that, the right atrium is getting connected to the left ventricle and um, left atrium is getting connected to right ventricle. This is further followed by the again switch at the outlet level. So this condition is called as completely corrected transposition of great arteries. This baby also had a VSD. So now why this baby had a severe cyanotic spell kind of a picture? Because it had a severe pulmonary stenosis, which leads to decreased pulmonary circulation and oligemia on the X-ray. So, in view of this completely corrected TGA, this baby was treated with modified BT shunt, blaloptasic shunt. This is in this the polyethylene tetrafluoroethylene graft is interposed between the subclavian artery and the ipsilateral pulmonary artery, so as to improve the circulation to the lungs and decrease the cyanotic spells. So these are all the cases which we have treated in our hospital. So the first one is a TAPVC, second one is this CCTGA. The third one, let's move on to the third case. So we had a 3-day-old neonate with a birth weight of 2.9 kgs. The baby was referred in view of increased respiratory distress and shock. The mother is a 28-year-old primigravida. The baby, she had no antenatal complications. Baby cried immediately after birth and the baby was shifted to the ward. The baby was started on direct breastfeeds. At 28 hours of life, the baby was noted to have off-color look and cold periphery. So any sudden postnatal collapse. So in these conditions, we should think of duct-dependent heart lesions. So then the baby was immediately shifted to NICU and started on low-flow nasal cannula and IV antibiotics. So then the vitals were done. So in any duct-dependent lesion, it's better to go and do the four-limb pulses, check the four-limb pulses. In this baby, the upper limb pulses were found to be bounding and the lower limb pulses were feeble. So the upper limb blood pressures were on the normal side, whereas the lower limb blood pressures were on the lower side. So this indicates that this baby having a duct-dependent systemic circulation. So the baby also had tachycardia and along with a short systolic murmur. 2D echo was done subsequently, which showed a severe coarctation of aorta with a good contractility of the heart, and PDA was open with 4 to 5 mm size. So this was the condition of the baby who had a sudden collapse, postnatal collapse in the ward after being initially normal. So these are the common conditions which we generally encounter in babies, either like as I have previously discussed, either respiratory distress with cyanosis, not responding to the initial management, or sudden postnatal collapse in the ICU, or subsequently having the failure to thrive. So based on this, the critical congenital heart diseases can present at any point of life. So then we should be aware of these conditions and then diagnose and treat properly. So this is the aortic arch view where we place the probe in the right subclavicular area, right second intercostal space, and then we can see the arch of the aorta. So this middle one being the right pulmonary artery, and this is the arch of the aorta. So this arch of the aorta will give rise to 3 branches. Right brachiocephalic, left common carotid, and left subclavian. So if you see the arch of the aorta and put a color Doppler over here. Here also in the 2D image also we can see a narrowing over here. And in the color also we can see the narrowing over here. So if the arch we found to be narrow at any point, then we should immediately suspect the coarctation of aorta. At any point of time, the clinical observation and performing the vitals takes the first priority, which that is preceded, then followed by the 2D echo. So even if we don't know how to do the echo and images, if we clinical acumen is good and we are able to suspect clinically, then we can timely diagnosis can be done for these babies, and they can be referred at the correct time for proper management. So whenever we suspect any baby to be having this critical congenital heart disease, so then we should optimize the pre-op. So after planning the surgery and all, before that we should optimize the fluid status for these babies. So fluids we should keep minimally only for the babies. So around 120 ml per kg per day is enough. We should optimize the fluid status based on the intravascular volume status and hepatomegaly. And respiratory wise, we should stabilize the baby if needed on ventilatory support. And then we should have an access to the central line. So either UVC or PIC line can be placed, and the baby can be started on some inotrope like dobutamine for improving the contractility as well as the perfusion. And if we suspect duct-dependent lesions, like in this case, it was a duct-dependent systemic circulation, so the PG even can be started. So the coarctation of aorta, interrupted aortic arch, and aortic stenosis, these are the duct-dependent systemic circulations. So in which they present with shock, circulatory collapse, acidosis, poor perfusion and pulses, and respiratory distress due to LV dysfunction on ductal closure on the as soon as the duct closes, that is on the day 2 or day 3 of life. So this baby was subsequently taken for coarctation repair, in which the narrow part of the segment is resected and end-to-end anastomosis will be done by the pediatric cardiothoracic surgeon. So now let's move on to the 4th case. In this, I'm discussing about a slightly bigger infant. So this baby presented with increased work of breathing, constant crying, and feeding problems. So what could be the differential diagnosis in such a case? It can be either a respiratory cause in which the baby had some aspiration pneumonia or viral pneumonitis picture or bronchiolitis kind of picture. So these all we generally treat with non-invasive breathing support. So still if it is persistent even after that with dyspnea. So this baby had dyspnea, tachypnea and tachycardia, and prolonged, the baby was going in shock with poor pulses, and so then needing the subsequent evaluation. The babies may also present with delayed development and failure to thrive if the baby is having any cardiac cause which is leading to these feeding problems and poor weight gain. So and then subsequently we do the chest X-ray. In this X-ray, the baby is apparently having cardiomegaly with a huge sized heart. So how to measure the cardiac shadow? We draw a line in the midline of the baby, and then we measure the maximum distance from the midline to the on either side, to the left side and the right side. It should be less than 0.55 is the ideal number. If it is more than that, then we say that there is a cardiomegaly. This baby is having a huge cardiomegaly. Then the ECG was done, which was showing left axis deviation with the deep Q waves in the first leads. Here you can see there are a deep Q waves here in the first leads, and um, AVL lead suggestive of infarction. So here the baby was having an unusual condition in which the coronary arteries, instead of arising from the aorta, they are arising from the pulmonary artery. So that is called as L-kappa. So the 2D echo also showed the dilated heart chambers with impaired LV systolic function. So whenever these coronary arteries arise from the pulmonary arteries, so the babies initially, if they are normal also, they might present around the first month or second month of life whenever the right ventricle is not able to take that much load as that of the left ventricle, and the circulation starts failing. So with impaired LV systolic function and shortening fraction was also becoming less, and the right outlet was dilated with the left coronary artery arising from the pulmonary artery. So this was the condition. The baby subsequently developed because of the failure of this heart, the baby developed secondary dilated cardiomyopathy. So here in this case, the baby will need the L-kappa surgery, in which the coronary arteries will be corrected and they will be placed properly. So the neonatologist or pediatrician will be to identify these kinds of different cardiac presentations early, and evaluate them at the earliest, and then refer them at the timely situation. So here this is a parasternal long axis view in which the probe is placed in the left side in between the two nipples, just below the nipple line, with the pointer pointing towards the right shoulder. Here we get this kind of picture. So in this, what we will see here, this is the left atrium and this is the left ventricle. From the left ventricle, this is the continuation of the aorta. Here we see a small line. This is the aortic valve. So in parasternal long axis view or plaques view, this is the picture. The topmost chamber, this is the right ventricle. And here this arrow pointing towards the interventricular septum. So here what we can see, the left ventricle is unusually large. If we are regularly doing the echoes, then we will be able to appreciate the chamber heart sizes and contractility, septal movement and all those. If we are doing at least 10 echoes, we will be knowing that if the chamber is huge and there is a septal deviation. Here we can see the left ventricle is kind of dilated and the septum is also more towards moving towards the right ventricle. And on putting the color Doppler, here we can see there is a blood regurgitating into the from the LV into the LA. So this is called as mitral regurgitation. And this is another view is this is the short axis view. Here we can see here this is in the middle, this is the aorta and this is the pulmonary artery. So in the short axis view, we can see there is some artery which is arising from the pulmonary artery, that is the left coronary artery. So in this way, this baby was diagnosed as having the L-kappa, and then subsequently this baby was taken up for the surgery. So how to differentiate whether any baby who is having distress is respiratory versus cardiac? In respiratory, there will be more of retractions in addition to tachypnea also. Whereas in the case of cardiac conditions, there will be only tachypnea. This is called as silent tachypnea or happy tachypnea, in which the babies will be having the fast respiratory rate, but there will not be much of the retractions. In intercostal retractions suggestive of more of pulmonary pathology. And the cardiac conditions also present with cyanosis, which is due to a right to left shunt of deoxygenated blood, which does not improve with increasing the FiO2. So in case of cyanotic lesions in which there is a mixing of the heart, either at the intracardiac level or at the ductal level. So this leads to the central as well as the peripheral cyanosis, which does not improve upon increasing the FiO2. On the contrary, if in the case of respiratory conditions, the oxygen desaturation is due to impaired oxygen transfer at the alveolar level and the VQ perfusion mismatch, and this cyanosis improves when we are increasing the FiO2. So in these conditions, to differentiate between the respiratory versus cardiac causes, we do the hypoxia test. This I will discuss. So the X-ray in the respiratory conditions features like consolidation, collapse. So these conditions will be seen RDS picture. So whereas in the case of cardiac conditions, so we will appreciate it in the form of either pulmonary oligemia or cardiomegaly, and specific heart shadows like boot-shaped heart in the case of tetralogy of Wallet. So these conditions can be seen appreciated on the chest X-ray. So then coming to the lung ultrasound, if it is a respiratory cause, then like DTNB. So any baby presenting with respiratory distress initially at birth and then improving subsequently, we treat it as TTNB, starting the CPAP and providing the respiratory support. So in those seen in the case of transient tachypnea of newborn, and if there is a history of B lines and calculate the RDS score based on that. And so we'll see the shed signs. So specific signs are there in lung ultrasound to respiratory conditions. Whereas in the case of cardiac, the CCF feature be there, pulmonary plethora can be there, and the baby also contract. So when does the heart diseases present? This we have been learning from our UG days. So it depends upon the closure of the duct in some of the cases, like duct dependent pulmonary and systemic circulations. And this is due to the alterations in the cardiac physiology secondary to changes during the transitional circulation, such as the closure of the PFO and the PDA. So that is the timing of presentation in cyanotic as well as acyanotic duct-dependent heart lesions. And the decrease in the pulmonary vascular resistance happens gradually after birth. So the VSD and all will present generally after around 1.5 months of life, around 6 weeks. When there is a increase in the pulmonary circulation, the baby presents with respiratory distress, failure to thrive, poor feeding, and all those factors. And the presentation will also be dependent on the nature and severity of the cardiac lesion. Suppose it's only an ASD, atrial septal defect, it may not present soon after birth. Whereas a severe like obstructive TAPVC, TGA and all will present soon after birth. So it also depends upon the nature and severity of the cardiac lesion. So next, coming to the order of evaluation of the baby. Whenever a baby has reached our NACU and we are taking the history, so we'll take the history based on this following order, like exposure to teratogens, the maternal viral any infections, so maternal any drug usage, and other comorbid conditions in the mother, and the history of presentation of the baby. Then coming to the vitals. So we will generally see the pulse rate. So pulse volume in all the 4 limbs, we should check whether it is less in the lower limbs also we should document, and we should check the SpO2 in all the limbs, and we should document the preductal versus postductal saturation difference. So the preductal saturation is generally taken in the right upper limb because the duct originates just beyond the right brachiocephalic artery. So then after that only the duct origin will be there. So generally we take the preductal saturation only in the right upper limb, and the postductal saturation can be either in the left upper limb or one of the lower limbs. So this SpO2 monitoring should be done at 24 hours of life in all babies to detect any congenital heart disease. So that also we will discuss in the subsequent slides. Then coming to the physical examination. So in this, we will go like the general examination, which we do, pickle, pallor, cyanosis, and then coming to the vitals, heart rate, respiratory rate, and SpO2 and temperature. So all these we will record and then go for the systemic examination, respiratory as well as the cardiac system. So then comes the role of X-ray, interpreting the X-ray, looking for cardiomegaly, looking for pulmonary circulation, and then subsequently the functional echo. I will discuss some of the echo views also in this session. So we should always try to have a multi-para monitor for our babies. Just to with ECG leads, we should note the ECG heart rate as well as the pulse rate. And then the perfusion index also will be there in some monitors, which should be also monitored regularly. Any difference in the perfusion index, so that we should monitor. And if it is more than 0.6, that is generally considered as normal. And as we have already discussed, reductal, postductal saturation difference, and to rule out the PPHN cases also, we generally see, and the invasive blood pressure monitoring, if possible, invasive blood pressure monitoring or non-invasive blood pressure monitoring. Generally, the IBP is better for any baby who is sick, ventilated, and is having in shock. Always try to place an arterial line and monitor the invasive blood pressure. So this blood pressure monitoring should be according to the our Zubro's charts, and we should note down the sentence and monitor the blood pressure accordingly. And so this was a monitor of a baby where the central venous pressure was also being monitored and the core temperature was being monitored for this baby. So coming to the clinical examination, so whenever we see any baby, after documenting the anthropometry, we shall also look for the cyanosis in the central cyanosis, that is in the gums, tongue, and the buccal mucosa, and also look for the respiratory rate and the work of breathing. So also look for the work of breathing retractions and do the respiratory distress score, whether it is a Downey score or SA score in case of preterm babies, and document the pulses in all the limbs and blood pressures also in all the four limbs. Four limb blood pressures are very important in identifying the drug-dependent conditions like coarctation of aorta, and we should also look for the pulse pressure. A wide pulse pressure indicates a hemodynamically significant PDA. And we will also be looking for capillary refill time, skin color of the baby, and the temperature should be monitored. Pulsatility index, which I have mentioned as comes in the some monitors, it should be ideally more than 0.6, and we should be noting the trend. It indicates the perfusion for the distal extremities. So then we'll look for the auscultation. So on auscultation, if it's a respiratory cause, we may find the wheeze, and then we should also note for the CREPS also, which increased lung fluid or any infection also in the lungs. And then we should auscultate over the anterior fontanelle and on the liver for Rohini. So this happens sometimes if there is any abnormal circulation in the baby, like vein of Galen malformation and any hepatic arteriovenous malformation. So we should auscultate over the liver and also the anterior fontanelle. So then coming to the cardiac examination, we will start from the inspection and then go to the palpation. So in which we should palpate for the thrill. So which can be seen secondary to a left to right shunt such as a BSD. And then we will locate the murmur. If at the size of the murmur, whether it means the intensity of the murmur, intensity of the murmur and the location of the murmur and the loudness of the heart sounds also we should see. So this gives us a clue about the possible cardiac condition that the baby might be having. And then in the parabdomen, we should be looking for the liver size, hepatomegaly, and the consistency of the liver. And we should also look for the liver sidedness, which happens in some cases of dextrocardia. There might be the situs inversus also. So we will adjust the fluid rate based on the size of the liver, and the size of the liver is also a good index of the systemic venous pressure. So hepatomegaly in any patient with cardiac disease indicates that there might be a volume overload, so we should restrict the volume. It also indicates the elevated venous fluid in a baby. So in that, volume resuscitation will be contraindicated. So then coming to the different types of clinical findings and the interpretation of the same. So as we discussed previously, a wide pulse pressure of more than 25 mm of mercury can be found in conditions like such as PDA and AV malformations and aortic regurgitation. So this is due to more of the left to right shunt, which causes the decrease in the diastolic filling of the heart, leading to the diastolic steal and causes the low diastolic pressure. Similarly, bounding pulses also are found in anemia, PDA, and vein of Galen malformation in truncus arteriosus. So we had a case in which the baby continued to have the bounding pulses, and then it was found to be a case of truncus arteriosus. So even small findings like this also correlate with the condition of the baby. So, and then AP window and aortic regurgitation. So feeble pulses in all the four limbs. If the pulses are feeble, then it indicates that there is a significant myocardial dysfunction and shock. So only lower limb feeble pulses are seen in both the femoral and peripheral feeble pulses are seen in coarctation of aorta and interrupted aortic arch. If there is a hyperdynamic precordium, then it suggests that it is a left to right shunt like PDA, VSD, and severe mitral or aortic regurgitation. If there is a palpable P2, then it indicates it's a severe pulmonary arterial hypertension. Third heart sound S3 gallop is seen in ventricular dysfunction and heart failure. Continuous murmurs are seen in PDA, AV malformations, and vein of Galen malformations. Wide and fixed split S2, this we rarely see in the neonatal age group, are seen in atrial septal defects. So coming to the causes of cyanosis in a newborn. So it can be seen in different cyanotic heart diseases. So let's see. So the duct-dependent pulmonary circulation, such as pulmonary stenosis, pulmonary atresia with intact ventricular septum. Here what happens, the blood flow to the pulmonary artery is limited. Thereby, the baby is dependent on the flow across the PDA for perfusion of the lungs. As the PDA closes, this baby is having the critical obstruction at the outlet level will present with severe cyanosis. So this is also seen in tricuspid atresia, tetralogy of Fallot, and Epstein's anomaly. So these are the common duct-dependent pulmonary circulation conditions. Then cyanosis can also be seen in parallel circulations like transposition of great arteries, in which um, there will be a switch of the arteries. From the aorta will be arising from the right ventricle, and the pulmonary artery will left ventricle, and there can be a mixing in the form of VSD and also at the level of the PDA. So these babies also will present with the cyanosis. Next, the third one is the intracardiac mixing lesions like the TAPVC and truncus arteriosus and single ventricle physiology. So in all these conditions also, cyanosis will be the presenting symptom. So we can remember it as all T's. So whenever there is a question like what are the common causes of cyanosis in a newborn, so we can say it as TAPVC, TGA, truncus, tetralogy of Fallot, and tricuspid atresia. In addition to this, pulmonary stenosis, pulmonary atresia with intact IVS, and Epstein's anomaly. So these are the common causes of cyanosis in a newborn. In addition to this, if there is a decreased pulmonary blood flow, it will present as a decreased circulation, the pulmonary oligemia on the X-ray, and these babies also will have the failed hyperoxia test, that is failure to increase the PaO2 in response to the oxygen. So how do we do this hyperoxia test? We will give 100% oxygen to the baby for around 5 to 10 minutes, and then we should get an ABG from the right hand, that is the preductal ABG we should get. We should document the PaO2 level. So this is very important. We will not be seeing the SpO2. We should see the PaO2. If the PaO2, preductal PaO2 is more than 150, it indicates that it is a pulmonary pathology. If the PaO2 is between 100 to 150, then there will be a dilemma whether it can be a congenital heart disease or a persistent pulmonary hypertension. So PPHN again, we will see pre-postductal difference, and then clinically, history-wise, clinically, and also the lability of oxygen, and also the echo-wise, in which we'll be seeing the bowing of the interventricular septum, TR-jet. So right-sided pressure kind of TR-jet and pulmonary arterial hypertension signs we will be seeing on the echo, and the response to pulmonary vasodilators like inhaled nitric oxide and sildenafil. So if the PaO2 is still less than 100 even after giving 100% oxygen, then that is called as a failed hyperoxia test. This is seen in those cyanotic heart disease conditions which we have discussed. So failed hyperoxia test is seen in conditions along with pulmonary oligemia if it is there. Then what we should think of? We should think of the conditions with decreased pulmonary blood flow, such as pulmonary atresia, tricuspid atresia, tetralogy of Fallot, and Epstein's anomaly. So here we are approaching the case of cyanosis based on both the X-ray picture and also the response to the oxygen, failed hyperoxia test. So if the baby has the failed hyperoxia test, and if the X-ray is showing pulmonary plethora, increased pulmonary congestion, then we should think of the other conditions like parallel circulation, DTGA, and mixing lesions like TAPVC, truncus, and PPHN. So in such a way, we can differentiate whether the type of the heart disease based on our clinical findings, clinical examination, and also on the X-ray. So in some conditions, the differential cyanosis will be seen. For example, in critical coarctation of aorta, interrupted aortic arch, and critical cyanosis. So reverse differential cyanosis can also be seen, in which the SpO2 is like less in the upper limb and more in the lower limb. So this is seen in conditions with the TGA, some rare conditions like TGA with coarctation of aorta and TGA with the pulmonary arterial hypertension. These are the common like MCQ questions you can remember in such a way so that you can answer those. So next, coming to we discussed about the common causes of cyanosis and how to differentiate the same based on the hyperoxia test and also the X-ray. And we will see the common causes of hypoperfusion in short. So as we discussed, the duct-dependent systemic circulations, they present as soon as the duct closes on around day 3 of life. So these are the coarctation of aorta, interrupted aortic arch, quadratum, and left-sided obstructive lesions like mitral and aortic stenosis, atresia, hypoplastic left heart syndrome, and obstructed TAPVC. And if there is a shock without obstruction, then we should also be thinking of myocarditis and cardiomyopathies. So what are the causes of congestive cardiac failure? So these are the 3 different presentations which we are discussing from the beginning of our presentation. So causes of congestive cardiac failure and failure to thrive are truncus arteriosus, TAPVC without obstruction, EAPVC, aortopulmonary window, AV septal defect, PDA, large VSD, ASD. They present with pulmonary congestion, tachycardia, tachypnea, cardiomegaly on X-ray. Because of increased blood circulation to the left side of the heart, left atrium will be dilated. And they also present with the hepatomegaly. So this is one important screening method which we should do for all our well babies in the postnatal wards. This is called pulse oximetry screening, in which we measure the SpO2 of the baby on the preductal SpO2 of the right hand and also either of the one foot at around 24 hours of age or earlier if the baby is being discharged. So when it is considered as pass or when the baby is safe to go home, if the pulse oximetry is 95% or more in the right hand and foot, and or there is a difference of 3 or less between the two. So like suppose if it is around 97 in the right hand and 95 in the foot, then it is okay. So it is normal and the baby does not need any repeat pulse oximetry screening, and the baby can be continued to have regular newborn care. So when we should do the retest, if the pulse oximetry is showing around 90 to 94% in either the right hand or foot, or a difference of 4% or more between the right hand and foot, then we should repeat the pulse oximetry measurement in 1 hour. So this should be, we can detect most of the heart diseases, which I will tell you subsequently. So then we should go for the second measurement. So this should be done after 1 hour. So if here the repeat measurement shows a pulse oximetry of 95% or more in the right hand and a difference of 3% or less between the hand and foot, then it is considered as the pass and the baby can be provided normal newborn care. So if the second measurement also shows the same, like around pulse oximetry of 94% in the either the right hand or foot or a difference of 4% or more, then we should refer the baby for immediate assessment in the form of echo. And when it is considered as fail at the first measurement itself, the pulse oximetry of 89% or lesser in either the right hand or foot, then we need not repeat the pulse oximetry screening again and immediately refer the baby for assessment in the form of 2D echo. So these are the four important methods where the critical congenital heart diseases will be detected. So the first one is the fetal echo, second is the pulse oximetry screening after birth, and then clinical examination, and the last one is the 2D echo. So if we follow all these stepwise, we can diagnose almost all the critical congenital heart diseases. So according to the AAP, there are the sensitivity of the pulse oximetry is different in different heart conditions. The sensitivity is high, more than 80% in conditions with critical pulmonary stenosis, DTGA, hypoplastic left heart syndrome, pulmonary atresia, single ventricle, TAPVC, and truncus. So it is of medium sensitivity in conditions of critical aortic stenosis, DORV, and tricuspid atresia. And the sensitivity is low, means the detection will be low in conditions of coarctation of aorta, Epstein's anomaly, interrupted aortic arch, and tetralogy of Fallot. The coarctation of aorta is also the most common condition, which will be missed on 2D echo, fetal echo as well. So that's why the pulse oximetry screening and clinical acumen helps. So how does this pulse oximetry work? So we will discuss briefly in 2 slides about how this works. This measures the percent based on the principle of measuring the percentage of hemoglobin that is saturated with the oxygen. So the the tissue will be transparent to the light in the near infrared spectrum, and the principle will be the absorption spectra of the oxyhemoglobin and deoxyhemoglobin will be different. So thereby the saturation will be detected. So this is according to the Beer-Lambert's law, which states that the absorption of a light at a given wavelength is proportional to the concentration of the substance and also the path length. So the pulse oximetry screening works on 2 different principles. That is, the first one is the spectrophotometry, in which the HbO2 and reduced deoxyhemoglobin have different absorption spectra, and photoplethysmography, that is the amount of light absorbed by blood in the tissue changes with the arterial pulsation. So these are the principles by which the pulse oximeter will detect the different HbO2 and deoxygenated HbO2 and gives us the saturation level. So this pulse oximetry is affected by different factors like poor perfusion of the baby and motion artifacts. If the baby is constantly moving the limb, then also they may not detect properly. And previous transfusions where we give the adult hemoglobin, and also if the baby is in acidosis or hypothermia. So these are the factors which affect the pulse oximetry screening. It also moves the oxyhemoglobin equilibrium curve to the right side in the case of acidosis, and also left side in the case of hypothermia and alkalosis. So these are the factors which commonly affect the pulse oximetry screening. So coming to the broad approach, whenever clinically and X-ray wise we have suspected the baby to be having a CCHD. So this is the broad approach we have been discussing till now, fetal echo, and then we should evaluate all murmurs and also any cyanosis and respiratory distress. We should rule out the congenital heart diseases. Some of the clues on X-ray being cardiomegaly, pulmonary edema, oligemia, and some specific cardiac shapes like egg-on string appearance in the case of TGA, snowstorm appearance, which I showed you in the first slide, in the case of obstructed TAPVC, and boat-shaped heart in tetralogy of Fallot. ECG wise, we'll be noting for signs of left ventricular hypertrophy in left-sided obstructive lesions and superior axis deviation in atrioventricular septal defects, Epstein's anomaly, and LTGA. And also we will look for the tachyarrhythmias and heart blocks. So the last will be the 2D echo. So I will discuss few of the 2D echo views because nowadays everyone is doing the functional bedside ultrasound. We should know at least the basics and what are all the different views and how to identify the structures in the heart. So in the subcostal view, the probe orientation marker will be kept on the epigastrium of the baby. And here we will see in the two methods. So short axis view and long axis view. The short axis view, the probe orientation marker will be in the 3 o'clock position. So, and this is the long axis view in which we keep the probe orientation marker towards the 12 o'clock position. So then here we will have the probe orientation marker on the left side for all the cardiac cases. We should keep on the left side. So what we are seeing here, this homogeneous echoic structure, this is the liver. Here we can see hepatic veins and the this black shadow which is coming and draining into the space here. This is the heart and this is the IVC. So most of us are able to assess the IVC for volume status, IVC contractility, eyeballing, and also we know if there is a dilatation of the IVC and more than 8 mm and also dilatation of the hepatic vein, then there is a volume overload for the baby and we restrict the fluid volume. So this is the subcostal sagittal view in which we will see the IVC, and in the subcostal views we can also look for the atrial, left atrium and right atrium, and also intraatrial septum and PFO, and direction of the blood flow, whether it is left to right or right to left in the PFO, is also plays an important role. Assessing that also plays an important role to diagnose PPHN as well as the cyanotic heart diseases. And ventricular contractility and eyeballing and intraventricular septum size and deviation also can be noted in the subcostal views. So this, if we tilt the probe, we tilt towards the left side, we will be seeing the aorta, which will be sitting just above the vertebral bodies. Here we can see this bright structures. These are the vertebral bodies over here. The lumen, we can see the lumen of the descending aorta, which is a very broad structure, which will be difficult to miss if we keep the probe correctly. And then we are also seeing the something coming from the aorta. This is the celiac artery, and then this branch here is the SMA artery. So the flow across the aorta can also be measured, and we can also, by tilting the probe slightly, and we can place a Doppler on the descending aorta. There we can see the systolic as well as the diastolic flows of the aorta. In coarctation of aorta, the diastolic flow will be very slow and it can lead to the tailing. So this is the subcostal short axis view in which we keep the probe marker at the 3 o'clock position. Here what we see, mainly we will see the location of for the situs solitus. So here we, what does situs solitus mean? Whether the position of the great vessels in relation to the liver and gastric shadow is correct or not is seen in this view. Here in the midline, you will be seeing the rounded structure. If we see this video, it will be pulsatile. So that is the aorta. And a little above and to the right side of the aorta, we will be seeing a flat structure, collapsible structure, that is the IVC. So here you can appreciate that this shadow on the right side. So our marker is on the left side. So whatever is towards the left side of the baby will be coming on the left side. So whatever is towards the right side of the baby will be coming on the right side. So here in this baby, we can see this liver shadow on the right side. So the sidedness is correct. So, and also the aorta is on the left side and the IVC is on the right side. And here we can see the gastric bubble on the left side. So this means that it is a situs solitus. And in the previous here, we saw that the whatever the chamber the IVC is draining into is the right atrium. So then that is also correct. So that means this is a situs solitus for this baby. And then the apical 4-chamber view. In this, what we see generally, when we keep the probe just below the left nipple in the fourth or fifth intercostal space to probe orientation marker at the 3 o'clock position. We will see 4 chambers like this. So this is an inverted view. For anatomical means orientation, we can keep it upward also. I will show you that video also. Here what we see, whatever is towards the left side is the left. So this is the left atrium and left ventricle, right atrium and right ventricle. So here we can see the eyeballing and contractility. How is the contractility of the heart? If we are regularly seeing, means we will know if the contractility is good or it is jerky contractility or whether it is poor. That means if there is a cardiac dysfunction, the contractility will be very slow. And here we can also see the flow across the valves. So here this the left side will be the mitral valve, right side will be the tricuspid valve. Flow across the walls and regurgitation also can be appreciated. And beyond, behind the left atrium, if we are seeing some veins which are draining into the left atrium, here you can see these dark shadows. And if we put a color Doppler over here, you can see some veins which are draining into the left atrium. Then it indicates that the pulmonary veins are draining into the left atrium correctly, and we can rule out the TAPVC. So, but still it doesn't mean that we should, if we suspect clinically strongly, we should always get it done from a cardiologist just to confirm that the following conditions are not there. So in the 4-chamber view, we will see all this: eyeballing, contractility, flow across the walls, interatrial septum, interventricular septum, and we can also note if there are any effusions just outside the border of the heart. If there is any collection like pericardial effusion, we can see it collected just outside. And if we tilt the probe, we can also see the opening of the aorta and also the pulmonary artery. So that comes under 5-chamber and 6-chamber views. So so first this left opening of the, when we are tilting the probe anteriorly, so we will see the opening of the aorta from the left ventricle first, and also then the pulmonary artery opening on from the right ventricle. So this rules out that there is no transposition of great arteries. So just play this video. So here what we can see, this is we have kept the probe orientation marker towards the down so that we can view the heart as we anatomically as we imagine. So that now this is the left atrium, this is the left ventricle, and this is the right atrium, and this is the right ventricle. So how will we identify the chambers of the heart? So so here we can see the right atrium. I have already told you, the wherever the IVC is coming and draining, that will be the right atrium. And also we will be seeing the interatrial septum and the flow across the PFO. So that also we should see. And this tricuspid valve, if you notice, it will be at a slightly lower level compared to the mitral valve. So this will be farther from the apex. Mitral valve is always the farther from the apex, and tricuspid valve is always little bit nearer to the apex. And whenever you observe the septal movements, so the tricuspid valve is more septophilic because it is the chordate tendineae are attached to the tricuspid valve, and the movement will be more towards the septum, whereas the mitral valve movement will not be more towards the septum. So this is how we will identify the tricuspid valve and the mitral valve. Right atrium we have discussed, and left atrium will identify based on the drainage of the pulmonary veins. So then how will we identify the right ventricle? So here we can see by the presence of the moderator band. What is moderator band? Here you can see a line, hyperechoic line, which is just parallel to the interventricular septum. Here you can see one line. So this is the moderator band. What is moderator band? After AV node, we all know that the nerves supplying the heart, they pass through the bundle of His, and then they separate into the right bundle branch and the left bundle branch. So the right bundle branch of nerves enter into this moderator band and supplies the right ventricle, whereas the left bundle branch passes through the interventricular septum itself. So that is why we don't see it separately. So by the presence of the moderator band, we identify that this is as a right ventricle. And then we will see the outflow tracts. Suppose if we tilt the probe anteriorly, so you can see here slightly a little bit the aortic valves, the opening of the aorta will be seen if we tilt the probe a bit anteriorly, and also the pulmonary valve can be seen if we tilt it more anterior. So that can be dealt with in detail in another class, like the views of the heart. So then the other view is the parasternal long axis view. Here we place the probe marker towards the right shoulder, just below the nipple line in the left parasternal area. So here, as I have previously described, so we will see the left atrium, left ventricle, interventricular septum, right ventricle. The chamber which is closest to the probe will be the right ventricle, interventricular septum, left ventricle, and mitral valve and aortic valve, and flow across the aortic valve. Always the aorta, whenever it is arising from the left ventricle, it should flow up and above. The flow should be above, and the pulmonary artery will be arising from the right ventricle, and the flow will be below. So that crossage should be there. So if that is not there, then we can think it of as a TGA, means there is a arterial switch is there. So these are the things which we assess in the plaques view. We will see the valves and also interventricular septum, contractility of the heart, and then we assess the ejection fraction in cases of shock. And we also see LAO ratio if we are suspecting the PDA. And outflow tracts and relation. I have one slide in the end where we have recorded the TGA. I'll show you that. And also the tricuspid valve and pulmonary valves also can be seen. This is the PSAC view, in which parasternal short axis view, in which the probe orientation marker will be towards the left shoulder. Here, what are the structures that we see? We will be seeing the left atrium, then the right atrium, tricuspid valve, right ventricle, and this is the pulmonary valve, and this is the main pulmonary artery. So in the middle, there will be the aorta, and you can see the aortic valves, which appear like the Mercedes-Benz sign. So this is the parasternal short axis view. Here also, we will be assess the interatrial septum between the left atrium and the right atrium, and the flow across the interatrial septum can be seen. Right here in this baby, the RA and RV are slightly bigger and dilated. We can see the contractility. We can see the pulmonary valve flow across the pulmonary valve, pulmonary regurgitation, and tricuspid regurgitation also can be noted. And in the same view, we can look at the coronaries. Here, if you can see, there is a small interruption over here. There is a black line, and also here. So these are the coronaries which are arising from the aorta, which is normal. In the case which we have seen, if they are arising from the pulmonary artery, you will be seeing from here. That image also I have shown you. So pulmonaries, by putting the color Doppler and decreasing the scale, we can identify the from where the coronaries are arising. So this is the parasternal short axis view. Then the other basic view which we all should know is the ductal view. High parasternal or ductal view. Here the probe orientation marker will be towards the 12 o'clock position, and we will be moving the probe a little upwards in the left second intercostal space, and then we will see images like this. Here you can see what is this middle one is the aorta, and then this is the pulmonary artery. Pulmonary artery will divide into right pulmonary artery and left pulmonary artery. Here you can see this division here clearly. This is the right pulmonary artery, and this is the left pulmonary artery. And if you are seeing the third one, then that is the PDA. So that why this view is called tripod view, because if you see three branches, three flows across after this pulmonary artery, it is called as the tripod view. So here, based on the flow across the PDA, here we can clearly see the gap. This is the descending aorta, and this is the pulmonary artery. If there is a flow across this space, then that is a PDA, and there are different methods to assess the severity of the PDA, like HSPDA and all that. I am not going into detail now. Here you can see the probe marker towards the top, and the flow is towards the probe. So whenever there is a red color jet, that means the flow is towards the probe. It will show as a red color jet. If it is away from the probe, it will be shown as blue color jet. Here it is a PDA with a left to right shunt. So measurement of PDA and all was already dealt in previous classes. So here you can see this video of a baby who presented to us with cyanosis on day 1 of life. So this baby was started on ventilatory support. So what is this view? This is a parasternal long axis view. We can see the left atrium, left ventricle, and aorta. So if we put the color over here, what we can see? From the left ventricle, the flow is going down, and also from the right ventricle also, the flow is going down. So this view on the plaques view is the double barrel view. So this was our own baby, which we have operated a few days back. So this is the transposition of the great artery. So here we have diagnosed with a simple bedside echo. So before the cardiologist interpretation of the echo, we can also diagnose if we know these basic views and know how to interpret them. With practice, we can do it. That was the double barrel view. So now we are almost at the end of the presentation. So immediate stabilization pre-op, how we will do, we will stabilize the temperature of the baby, we will normalize the blood glucose, stabilize the airway breathing circulation, ventilate the baby if needed with the lines, restrict the fluids based on the liver enlargement and intravascular volume status, and inotropes if indicated, start prostaglandin in a if you suspect duct-dependent lesions, and immediately take a cardiologist opinion, because PGE1 is contraindicated in few conditions like which present with left atrial hypertension like obstructed TAPVC, mitral atresia with restrictive PFO, and hypoplastic left heart syndrome with restrictive PFO, TGA with intact ventricular septum, and restrictive PFO. Any of these conditions, we should not start prostaglandin, but you can start in emergency purpose and immediately get the cardiologist opinion. So these are the management of the common conditions. ASD we don't do initially in the neonatal period. Device closure can be attempted if symptomatic at around 3 to 4 years of life. VSD presents with murmur over the left lower parasternal border, CCF, and cardiomegaly. Whenever the pulmonary blood pressures decrease, the baby will start presenting. Initially medically managed with diuretics, and then patch closure of VSD, not amenable for the device closure. Then AV septal defects commonly associated with Down syndrome. They present with ejection murmurs or holosystolic murmurs and also failure to thrive. Medical management with diuretics and surgical correction can be attempted at 4 to 6 months of age. Commonest presentation where the premature babies present with are the PDA. There we can see the continuous murmur over the thrill over the left precardium. Murmur can be auscultated. The baby presents with cardiomegaly and signs of CCF and pulmonary overcirculation, increase in the respiratory settings, oxygen requirement, and feed intolerance. All this will be there. With along with the bounding pulses, wide pulse pressure, everything will be there. And so if we suspect the PDA, I've shown you the ductal view. We can put a probe and see, measure the PDA, and then start the medical management if indicated by the scenario like HSPDA, or we can treat with the fluid restriction initially and see if medication is required, and then if medical management fails, we go for the surgical PDA ligation. So next is coarctation of the stenosis, aortic and pulmonary stenosis. They present with ejection murmur over the valve region. They treated with catheter-based balloon valvuloplasty in the neonatal period. Coarctation of aorta, the clinical scenario which we have discussed already. So we should start PG even to keep the duct open, and arch view also I have shown, where we can see the flow across the descending aorta. So and diagnose the coarctation of aorta. And tetralogy of Fallot, malaligned interventricular septum with VSD overriding aorta, right ventricular obstruction. They present with cyanotic spells. We should give oxygenation and Nietzsche's position and morphine and propranolol, sodium bicarbonate and phenylephrine. So in our case, we have managed the CCTGA case with the modified Blalock Taussig shunt initially, followed by complete repair of VSD and the PS. TGA parallel circulation, double barrel sign I have shown you. So then in the apical four chamber view also you can see the which blood vessel is arising from which chamber. So whenever anything is abnormal, we should immediately take the cardiologist opinion. So this baby underwent the arterial switch operation. First initially we started PG1 followed by the surgery. TAPVC, PAPVC. So in the TAPVC, there are different varieties like supracardiac TAPVC, cardiac TAPVC, where the pulmonary veins drain into the coronary sinus, and infracardiac TAPVC. So obstructed TAPVC presents with pulmonary venous hypertension, respiratory distress, cyanosis within the first day of life, and X-ray of lungs will show whiteout picture with no cardiomegaly. That X-ray we have already seen. So if we see such a picture with a baby with cyanosis not improving, then immediately we should suspect the obstructed TAPVC, for which surgical repair is the only option. Unobstructed TAPVC may present with only cyanosis. So in obstructed TAPVC, PGE1 is contraindicated because there will already be the left atrial hypertension. So PGE1 will worsen the scenario. In hypoplastic left heart syndrome, as we have discussed, present with shock in the neonatal period. So we can start the PGE1 for patency of the PDA, followed by balloon atrial septostomy and palliative therapies. Post-operatively, how do we monitor these cases? This requires very close monitoring for the complications which may arise in the post-operative period, like low cardiac output or shock, may present with CCF, arrhythmias, pulmonary and systemic hypertension, and we should manage them with multiple inotropes, vasopressors, antiarrhythmics if needed, fluid titration, diuretics, and pulmonary vasodilators as needed. The other complications being electrolyte abnormalities, acidosis, sepsis is a possibility, should be kept in mind. Multi-organ dysfunction. Initially, the babies will be on dialysis. As the urine output normalizes, we will slowly take off the dialysis, and they are also susceptible to acute kidney injury, seizures, and respiratory complications like pulmonary dysfunction, effusion, and chylothorax, which also should be kept in mind whenever we are managing a baby with post-operatively cardiac care. So these are the different presentations of cardiac diseases. We have discussed the incidence, risk factors, and different presentations, X-ray, echo findings, clinical assessment, and then pulse oximetry screening, how to do bedside echo, when to involve a cardiologist, how to immediately take the baby for further care, and how to improve the outcomes of these babies. So the outcomes of the babies are nowadays improved by advances in the prenatal diagnosis, where we have an idea in the prenatal fetal echo itself, followed by postnatal pulse oximetry screening, timely diagnosis and initiation of appropriate cardiac care before the occurrence of complications. So the timing of the identification and the timing of the surgery also plays an important role in number of cardiac diseases, like before complications like development of pulmonary vascular disease, recurrent infections, failure to thrive, developmental delay, and neurological deficits itself. If the baby is given appropriate care, then the outcomes will be better. So cardiac surgery in appropriate centers with good, highly experienced surgeons also plays a major role, and improvement in the post-operative care have led to the improved outcome in these babies. So, so this is our today's presentation. If you have any doubts, you can just type in the chat box or just send a message to us. Then I will try to reply to my best knowledge. Thank you all for your patient listening, and thank you once again.